Left main coronary artery stent migration. Definition. The left coronary artery is an artery that arises from the aorta above the left cups of the aortic valve and feeds blood to the left side of the heart. Branching. It typically runs for 10 to 25 millimeters and then bifurcates into anterior interventricular artery and left circumflex artery.
Hey everybody, it's Matt from KenHub, and in this tutorial we will be talking about the left coronary artery. The coronary circulation is responsible for nourishing the heart during its tireless effort in pumping blood around the body. The first branches that radiate from the ascending aorta as it emerges from the left ventricle are the left and right coronary arteries, which directly provide an arterial blood supply to the cardiac muscle. As just mentioned, the focus of this tutorial is the left coronary artery, which you can see highlighted in green on this image of the anterior view of the heart. The left coronary artery, along with the right, arises from the bilateral aortic sinuses, which are situated just distal to the aortic valve, and runs between the left atrium and the trunk of the pulmonary artery. It supplies the left atrium, a large portion of the left ventricle, a small portion of the right ventricle, the interventricular septum, and the sinoatrial node in approximately 40% of the population. Its two main branches consist of the circumflex branch that supplies the posterior surface of the heart by running on its left side within the atrioventricular groove. The anterior interventricular branch, which runs inferiorly down the interventricular groove to the cardiac apex, where it anastomoses with the posterior interventricular artery. This video is more fun than reading a textbook, right? If you want more videos, interactive quizzes, articles, and an atlas of human anatomy, click on the Take Me to KenHub button. It is time to say goodbye to your old textbooks and say hello to your new anatomy learning partner, KenHub. See you there!
Function. The left coronary artery and its branches supply the majority of oxygenated blood to ventricular myocardium, and additionally to the left atrium, left atrial appendage, pulmonary artery, and aortic root. Importance in cardiovascular disease. Coronary artery disease is generally defined as a gradual narrowing of the ligament of the coronary arteries due to arteriosclerosis.
It is gently and easily deployed over the thrombotic lesion by retracting a protective sheath, and because of its inherent design and properties, it exhibits no recoil. As spasm is relieved, the vessel diameter increases, and the stent follows in expansion and continues its scaffolding of the artery. Finally, as the thrombus dissolves, the stent expands further to absorb the gap left by the dissolving thrombus, thus maintaining a perfect apposition throughout the remodeling process of the vessel. This allows the free mesh to cover the side branch ostium. The wide opening provides uncompromised access to the side branch for optional further treatment. The shape memory properties of nitinol make the disconnected ends return to their initial position and safely appose to the vessel wall.
Stent. A stent is a tube or other device placed in the body to create a passage between two hollow spaces, and stenting is the placement of a stent. Stents usually are made of metal mesh, but sometimes they are made of fabric. Fabric stents are also called stent graft and are used in a larger arteries.
Hello, today we're going to be catheterizing the left coronary artery coming from the right radial artery. I've selected an 035 guide wire and we have a radial artery sheath in place. We're going to be slowly advancing the guide wire, which you will see assume its J-tip shape as it emerges from the sheath. I have a mental road map in my mind of where this wire should be heading, and I'm looking to see whether I get any resistance as I advance the wire to warn me that I'm in any small branches, and you can see I'm getting a little bit of resistance there. So what I'm going to do is just bring in the guide catheter, but not take the catheter past the tip of the wire. And we'll take a small angiogram and see exactly what's going on, and we can draw ourselves a road map. So we'll take an angiogram here. And perhaps the wire was just going into a small branch. Doesn't seem to be any particular problem, but I now have a very detailed road map to show me where I need to go. And we can see the wire passing on fine now. As we come up to the elbow here, this is commonly where the wire can get into some small branches, but there we saw it negotiate the arm without any problems, and it's heading up now in the brachial artery. I'm just moving guide catheter and wire together now, up through the subclavian artery. As we advance the wire here, we're being careful to avoid going into the head and neck vessels. And the wire tip is now advancing down the innominate and heading to the left of the screen into the ascending aorta. And just there I could feel the resistance as the wire came up against the aortic valve. So I'm going to fix that wire there now. And with the wire position fixed, I'm advancing the catheter over the wire and down into the aortic root. So now we're going to take out the 035 wire. It's done its job of negotiating us, of navigating our way, to the ascending aorta. What we don't want is for that wire to go down any coronary arteries. I'm going to bring back that wire, and what you'll see happen is that the guide catheter will assume its preformed shape. In this case we have a Judkins left 3.5 catheter. Now we need to know where we are in relation to the left main coronary ostium at this point. So we can take a small scouting shot and we connect up our giving set, ensuring that we have no air inside the system. Before taking any shots, however, it's very important that you always look at the pressure tracing, and you should do that before you take any injection. And that's to ensure that there isn't any damping of the pressure trace, which might suggest that the catheter is either up against the wall of either the aorta or the wall of the left main stem, or it's found its way into a small branch vessel, either of which might be dangerous if you were to inject at that time. We're taking a gentle puff here, and we can see that we're very close to the ostium, but not quite selectively in it then. What we're looking for is to see the catheter move into the artery, and you often will see it jump across, like that. And again, we check our pressure tracing, gentle injection. And this catheter at the moment is not correctly orientated. It's pointing up a little bit into the roof of the aorta. So what I'm going to do is just gradually pull it back and torque it a little so that it's lying much more in a horizontal plane. Again, checking our pressure tracing is okay, a gentle injection, and we can see the outlines of the coronary vessels then. You can then go ahead and select your different views. If we come now into a PA caudal view, about 30 degrees. And this is quite a good one for outlining the left main stem. Take a cine shot here. We can see that we've got a very severe stenosis in the proximal LAD there. And that's coronary angiography of the left coronary artery.
Pros: you don't need major surgery. Most patients do not require general anesthesia. Major complications are uncommon. And cons: the catheter insertion sites could become infected or bleed heavily and will likely be rosed. Other rare complications include heart attack, stroke, and sudden cardiac death.
That stent thrombosis is not uncommon within the first 2 years after primary percutaneous coronary interventions in ST segment elevation MI. A question that interventional cardiologists frequently ask is whether there is a difference between the incidence of stent thrombosis in bare metal versus drug-eluting stents, and whether adjunctive pharmacology has any impact. Now in circulation, researchers answer that question in evaluating data from the Horizons AMI trial that included more than 3,500 patients with acute MI. Definite or probable stent thrombosis within 2 years occurred in 4.4% of patients, of which about 1/4 were early and about 1/2 late. Interestingly, there was no difference between thrombosis in bare metal or drug-eluting stents. As far as adjunctive pharmacology is concerned, there was more acute stent thrombosis in patients randomized to bivalirudin monotherapy versus heparin plus a 2B3A inhibitor, whereas stent thrombosis after 24 hours occurred less frequently in patients with bivalirudin compared with heparin plus a 2B3A inhibitor. There was something that appears to have really made a difference. Pre-randomization to heparin and a 600 milligram clopidogrel loading dose were independent predictors of reduced acute and subacute stent thrombosis. What's the take-home message for acute MI interventions? It seems that using bare metal stents or DES makes no difference, but early antithrombin therapy and preloading with clopidogrel may reduce early stent thrombosis and improve prognosis in these patients. I'm Peter Block, and this is a CardioSource Heart Minute.
Conclusion: you should plan to study overnight at the hospital. You will need to make arrangements to have someone drive you home when you're ready to leave. Be sure to follow your doctor's instruction about taking your medications. Thank you.